good afternoon, everyone, and a very warm welcome. We are glad you joined us today in our Facebook Live today. I'm Shamila Parantaman, and I'll be your moderator for today. Before I introduce the speaker for today, just a little reminder, if you have any question during the talk, feel free to type them in the comment box below in the live stream. I bring the questions up during the Q&A session and they'll be answered by the speaker. And also, don't forget to like and share this live video later on. It's an honor to have with us today an esteemed and experienced speaker, Professor Dr. Chin Kin Fah, who is a consultant general surgeon and a governor of Asia Pacific Metabolic and Bariatric Surgery Society. Professor Dr. Chin graduated in medicine from the University of Aberdeen in 1993. He was awarded intercollegiate fellowship in general surgery and upper GI surgery and certificate of completion of specialist training in United Kingdom in 2005. He completed his senior fellowship in upper GI and laparoscopic surgery in Adelaide in 2006. He was appointed as consultant general surgeon with special interest in upper GI surgery in Yorkshire under NHS UK 2006 to 2008. Joined UM as an associate professor in surgery in 2008, and he was appointed as a full professor in surgery and head of upper GI surgery in 2009. His topic today will be on bariatric surgery. I'm sure everybody know by now that it is one of the leading surgeries for now. So let's hear more from Professor Dr. Chin.
Thank you very much, Ms. Shamila. Thank you for moderating this session. And welcome everyone, the patron of Assunta Hospitals. Good afternoon, ladies and gentlemen. For this afternoon, I would like to share with you my experience in bariatric surgery and metabolic surgery. What I would like to highlight to you is that why are we talking about weight loss surgery this afternoon? And is it really a cosmetic surgery or rather a metabolic surgery? And to bring you some understanding of the science behind metabolic surgery and the outcome and the cost effectiveness of this surgical intervention. Ladies and gentlemen, I am sure everyone knows that obesity is a public health burden. And especially in this COVID pandemic time, I'm sure you have heard about the risk of dying from COVID-19 should you be an elderly patient, should you be a patient with obesity, and should you be a patient with diabetes. That put you at a really, really high risk of dying from this COVID-19. And you can clearly see that obesity is not a new problem. It's been around the corner for so many years, and each year, many people die from this obesity. And in fact, I'd like to highlight to you that Malaysia indeed is the most obese country in Asia. And if you look at the prevalence of obesity, well back in 2014, you can clearly see that about 13.3% of our Malaysian population already was obese. And this can even highlighted in the recent figures. And what's happening in Malaysia is that you can clearly see that if you are a female from an ethnicity of Malay or Indian populations, then your chances of being obese is very high. And indeed, if you are a housewife and not working outside the home, and that actually put you at risk of obesity as well, based on our data in Malaysia. And if you are children in standard 5 in this study from Kuala Selangor, and you can clearly see that the risk of the obesity among these school children was rather high at about 10% of their population in school. So there is a very high risk way back many years ago. And what about some recent figure? If you look at the figure that we got over the years from 1996 to 2015, you can clearly see that the risk of obesity has increased over the years. But is it because we are not active physically? But in fact, on the contrary, you can clearly see that our population actually becoming more active over the years. But that doesn't mean that being more active, your risk of overweight or obesity actually decreases. But in fact, it has increased over the years on the contrary. So if you look at the most recent figure, in 2019, you will be surprised because one in two of the adults in Malaysia are actually overweight or obese. One in two. And in fact, one in two of you actually would have a lot of fat in your abdomen, in your tummy. If you look around you, how many colleagues or friends you have in the office, one in two of them would be obese or overweight. And of course, if you are female, they really put you at high risk. And unfortunately, the recent figures suggest that Indian population are actually more at risk. I think predominantly related to your dietary habit and to the background of, of the lifestyle as such. And of course, all this obesity would contribute to other diseases such as diabetes, hypertension, and heart diseases. So if you are obese, your risk of having diabetes, hypertension, and heart diseases increases with time. And what about diabetes? Is it common in Malaysia? And I'm afraid to say that one in five of you would have diabetes over the years. And that is regardless whether you do know that you have diabetes or not, or have you been diagnosed to have diabetes. And in fact, if you look at both cohort of patients who know or who doesn't know that they have diabetes, that actually increases significantly over the years. And that really put Malaysia at a very high risk of having diabetes. And this is the chart that I looked at in 2007. And if you look at the color of the map, and of course, the lighter the color, the less likely for the population to have diabetes compared to those with very dark color. That country really will be very sick with more people with diabetes. And in 2007, you can clearly see that Malaysia already was very dark compared to the rest of their neighboring countries. And what about if you projected in 2025 years in the future, where back in the future, where would be our prediction? I'm afraid to say that Malaysia is indeed darker and darker. In other words, more of us would be dying from diabetes. And if COVID-19 is still around the corner, more of our Malaysians will be dying from COVID-19. And I'm sure that is why you clearly see that our death rate in Malaysia is rather high compared to other countries currently. And this translated, of course, into death. And in fact, if you are obese, the chances more than 58% of you would have type 2 diabetes over the years. And 21% of you would have ischemic heart disease. And 20% of you would have a stroke somewhere in the future. And of course, 40% of you would have hypertension. And moreover, most of you would have developed cancer somewhere down the line. That is how badly this obesity and overweight been to our health. And of course, you can clearly see from this very established graph that you can clearly see that as you are obese, when you reach the cutoff point of 32 for Asia Pacific population and 35 for the Western population, your risk of dying from these diseases is extremely high and it's going up to the roof. That is the truth. And this is established graph. And what about, is there any differences between being an Asian compared to those who are Caucasians in Europe and United States? Sadly to say that if you look at this graph, I'd like to highlight to you that that line, which is red in color, represent the Europeans or the Caucasians, and that purple in color or violet in color represent our Indian colleagues, and the green represent the Chinese. And you can clearly see that based on the races, we are actually the race that are more likely to acquire diabetes for a specific body weight. And if you look at obesity being at, let's say, overweight at 28, BMI of 28, and you can clearly see that your risk of having diabetes actually going up if you are Indian, if you are Chinese, compared to your European friends. And this risk is actually significantly higher, regardless of your body weight being overweight or being obese. So as long as you're overweight, your chances of having diabetes is extremely high. What can you do about it? Of course, this is the standard equations. We would say that please look after your diet, take a very low calories diet, go and exercise, set a realistic goal for your exercises, change your behavior of eating. Maybe perhaps over the counter you'll find some drugs that might say that that can help you to lose weight. But are they the solutions? Can you add them all up and help you to lose weight? And that is the big questions. And what is the pyramid of treatment? Of course, as a doctor, I would first of all advise you to change your lifestyle. Look after your diet, exercise more. Drug therapy up here is still under development, and most of the drugs that have been development has been largely ineffective with significant side effects. And that remain perhaps surgery being the last option, but being the pyramid at the top being the most effective way of actually controlling the weight. Why is that so? I'm just going to bring you some slides and some scientific evidence. It could be rather complicated, but I like to make it very simple for you to understand. Do bear with me. First, I like to tell you that I'm sure everyone will have watched this Biggest Loser that has become such a popular program. Even when I was a medical student many years ago, it was a hot program for us to watch. If you lose your weight within 30 weeks, you won a $1 million US dollars or something like that. And that really is a driving factor. Money is a driving factor for this participant to lose weight, cut off their diet, exercise more. And of course, fantastic result, as you can clearly see from this graph. Those are well-known figures now because of that competition in the televisions across the world. And it's a global program. And you can clearly see that that is a significant result after 30 weeks of intensive exercise and dietary modifications and sheer determination just to want that money. And what happened to them? That is a big question after that. And well, when I look at this paper, I was astonished as you are. What happened to them 6 years after the Biggest Loser competitions? And I'd like to point to you that this is a rather complicated table, but out of the 14 of the 16 winners, we managed to collect some data and we look at them, what happened 6 years later. Bear with me. If you look at the weight, and this is the baseline, and this is 30 weeks of intensive competitions, they managed to lose their weight and won the prize. 6 years later, they put up the same amount of weight again. They regained the weight. Is it because they put on more fat? Yes, if you look at this, they lost the fat and they pound out the fat. But did they actually lost any muscle? No. Their muscle weight remained the same despite 6 years later. That means that they actually been active even despite 6 years later. Their physical activity output was the same. In other words, they put on weight, but actually they have the same amount of muscles because they still go to the gym every day. They still exercise a lot. They run marathons. They're still very healthy in that sense that they have a lot of muscles. But as you can clearly see from this chart here, this is the body weight. 6 years later, they put on their weight again. And there is no difference in terms of the muscle weight, but the fat amount of fat in the body actually increased 6 years later. So that explains to the fact that they actually put back the same weight again. And why is that so? And this is very rather interesting because if you look at this 6 years later, what we call the basal, the resting basal metabolic rate actually decreased. What does that mean? It means that if they have a simple little bowl of rice 6 years later, they were not able to burn that amount of energy compared to 6 years before. In other words, their ability to burn extra energy has very much reduced. So even if they don't eat a lot, they still put on the fat. And that is because of the way your metabolism of the body actually changes after a period of rapid weight loss. It just happened. Your metabolism has changed. And this is rather disappointing because if you look at this graph, if you take your diet and then you change your behavior, and if you combine both of them through sheer determinations and sheer help from the psychotherapist, and but 5 years later, you still put back the same weight again. That is rather disappointing and depressing, in fact. And if you look at drugs, of the drugs, Orlistat perhaps is the only one that actually achieve some little effect. But if you look at this graph, the effect is not rather high because you're talking about only a few kilograms of weight loss if you continue to take your medications. And most of the medications that are supposed to be on the pipeline to make a breakthrough did not actually achieve that at the moment because of the side effect. I'm not saying that it will not happen. It will happen in the future that we will be able to modify our genetics profile because human as a race, our evolution is such that we are becoming fatter and fatter. That is our genetic evolutions. So in order to reverse that, we must intervene perhaps with genetic therapy, but it's not here yet. So what is around at the corner at the moment is rather interesting. In fact, it's a simple form of surgery and what we call bariatric or metabolic surgery. And if you look at this type of surgery called gastric bypass surgery that I do, and you can clearly see that the effect of weight loss over the years, up to 10 years, remain good. And in fact, if you look at the data, it maintains so even after 20 years. In other words, if you have a gastric bypass, once you lost your body weight, usually about 70% of your excess body weight, the 70% of that excess weight that somehow you gain because you've been putting on weight, that 70% of that excess weight you can lose through this form of surgery. And that is a lot. That is a lot. And why is that so? But sheer biggest loser, they are not able to maintain their weight even by 6 years down the line. They all bounce back up. I think if you look at this just like an elastic band. So if you pull your elastic band down, and then when your metabolic changes, then it bounce back again. So there's no control of your weight. But the gastric bypass is a mechanism that we still somehow don't quite understand yet at the moment. But somehow that mechanism, just like having something to hold onto the elastic band and prevent it from bouncing back. So it's a mechanism that somehow, just like a key or a lock, that somehow lock the weight and prevent it from going back up again. Of course, there are some who may regain weight for some other reasons or some other obvious reasons, but majority of them, I'm talking about the majority of them actually able to maintain their weight. And if you look at some of these very detailed scientific data from very world-renowned journal. I'm talking about world-renowned journal. New England Journal of Medicine is just like #1 medical journal in the world. And if you look at this paper, that look at if you change your lifestyle intensively with medication, diet, and exercise and everything else, if you have your type 2 diabetes, and what happened to your risk of dying from cardiovascular disease, from dying from a heart attack or dying from a stroke. If you look at this, of course, if you are undergoing intensive therapy, medical therapy with medications, exercise, lifestyle changes, your weight will reduce, of course, compared to those who did not receive those kind of intensive treatment. And, and of course, your waist circumference will reduce, you become thinner, and you become much more fitter because of the exercise that you do, and your control of your glucose level is better than ever before. But unfortunately, all this did not translate into a better survivor. In other words, your risk of dying from cardiovascular disease, having a stroke, having a myocardial infarction, a heart attack, is equally the same whether if you're on the intensive medical therapy or not, compared to those who just having a normal as usual medical treatment. This rather surprise and very somehow interesting. But if you look at the bariatric surgery or the metabolic surgery we do, in fact, if you have the surgery, the chances of you dying is very much reduced. And from this graph, we can calculate that should you be able to lose weight from having a bariatric surgery, you actually save 10 years of your lifespan. You live longer by 10 years. And that is significant. Look at what you can do in 10 years. That is a big difference. And of course, if you look at my patient many years ago, and that was he before the surgery together with a wife, and then after the surgery that is half of the waist circumference is gone. And but I would like to point out to you the most important thing is that resolution of type 2 diabetes. Straight after surgery, he came off from insulin, he came off from the medication, and I'm saying that the effect is astonishing because the night after surgery, he no longer need to have insulin. The blood glucose just returned back to normal. And of course, within 6 months, her hypertension would have resolved. And of course, with loss of weight, her sleep apnea were gone. And that actually translate into better lifestyle and more confidence. And of course, medal winning, trophy winning, and that changed the lifestyle as well. And of course, his medications pre-op was enormous. And after surgery, none of the medication that he need to be put on. And if you look at this data, this is the percentage of improvement or resolution. And you can clearly see that if you have diabetes, your chances of resolving from that is very high, more than 90%. If you have hypertension, similarly, is more than 90%. And you have reflux or severe reflux disease with heartburn, regurgitations, chest pain, whatnot, coming from the reflux because of your weight, that actually reduces as well and improved to significantly almost 100% cure from that. And same for sleep apnea, your glucose level, your lipids level, your cholesterol level also control. If you are joint pains from arthritis, that will resolve as well. Basic sciences, your weight reduce, your joint survived. And of course, if you have stress incontinence, going to toilet all the time to pass urine, with your weight gone, your lifestyle return to normal. You don't have to rush to toilet. And of course, if you have headache from the high blood pressure in your brain, we call intracranial hypertension, that actually within 1 month resolve. Your headache will be gone. And of course, if you are infertile because of your weight, your metabolism will resolved, improved, and you become indeed very fertile. So we always say, try to avoid pregnancy within the first year because you are actually becoming very fertile. And, and of course, if you look at this on a much bigger study, a longer time period, with a good number of subjects, and that is what I showed you earlier on, there are good subjects, a control population who didn't have surgery, and then we just look at the green graph of those who have this standard gastric bypass surgery. And you can clearly see that those who underwent gastric bypass surgery, the chances of survival is much better compared to those who did not have the surgery. They live longer. And if you look at just diabetes alone, and at the top chart here, this is about remission from diabetes. We don't say cure because cure will be too strong a statement to make. We say remission, which means that you are able to come off from your medications. You are able to stop injecting your insulin. But of course, within your body, the disease remains. You may still have diabetes, but is in remission, under control. And if you look at this, those patients who underwent surgery is in dark blue. Those who did not underwent surgery is green in color. And you can clearly see that the chances of your diabetes being resolved in remissions is significantly higher than those who did not have surgery. And this is the same 10 years later. And if you look at those, again, similarly, in the bottom chart here, blue being those who underwent surgery, and green being those who did not undergo surgery, who are obese. We are talking this group of population are all obese and morbidly obese. And you can clearly see that the incidence of diabetes, if you do not have diabetes before this study, that is before this surgery or commences, then your chances of developing diabetes actually reduce compared to those who did not have surgery. So in other words, surgery can prevent you from having diabetes in the future as well. This is rather interesting because one of my patients in Assunta came to see me because she wanted to lose weight. And her main concern is because her family are all diabetic. She's still young. She doesn't have diabetes, but she knows if she continues to put even more weight, she will become a diabetic. And she doesn't want to be diabetic because she has seen all the side effects from that. So she told me, can you prevent that from happening? I think this data is rather interesting because from this data, you can clearly see that, yes, we can prevent the development of diabetes should you be able to lose weight following surgery. So that is a very strong data. And of course, if you look at this, this is the cumulative diabetes incidence. That's the development of diabetes over the year. And those who are under surgery, their chances of having diabetes is much lower than those who did not have surgery. So that is very clear. And of course, this translates into fatal cardiovascular accident. For example, if you have a heart attack or you have a stroke, your chances of dying from that is actually very high should you not have surgery. So you can clearly say those have surgery are having less chance of having a stroke or a heart attack from this graft. And if you look at the chances of cancer, developing cancer, similarly, those who had surgery on this graph here in the brown line compared to those who did not in blue line, your chances of having cancer, especially among women, are actually much lower. So that is very interesting. So in summary, if you look at this, this is the BMI, the body mass index, as you know, whether regardless whether you are very, very obese or just a bit overweight or obese, then the effect is still the same. If you have this weight loss from this surgery, your chances of dying is much reduced. You are in favor of surgery on this side, on your left-hand side, and your chances of having cardiovascular disease is very much reduced, your cardiovascular death, and your chances of having cancer is very much reduced. And of course, you have more diabetes prevention. So these are all very strong data because if you look at this were published in world-renowned journals. You're talking about New England Journal of Medicine, you're talking about JAMA, you're talking about Lancet. These are #1 medical journal in the world, and it's been endorsed. And you can look at that similarly, simple term. If you have surgery, the chances of control glucose level in your blood is much better when compared to those who just change their lifestyle or with optimal medical treatment. So these are very strong data, and it's been published across the board. These are the number of papers being published well early on in 2001 to 2008. And you can clearly see that, look at the list of publications, and majority of them actually in favor of surgery and all those data there. So where do we stand from here? And if you look at long-term follow-up, yes, the effect is still there, 5 years, and compared to those who did not have surgery. So it does translate into better quality of life. And regardless whether you're morbidly obese, with a very big size with BMI of 40 and above, or 50 or 60, compared to those who just have BMI of 32 or even 30, there's still the effect on the diabetes is still remain the same. So what do we do in Asia Pacific? As I come from Asia Pacific Metabolic and Bariatric Surgery Society, and this is our guideline, being very different compared to the West, because our risk of having diabetes and dying from this disease is much higher than the West. So in the West, the cutoff for bariatric surgery is BMI of more than 40. But in Asia Pacific, it's BMI more than 37. If you have BMI more than 37, you are basically sick enough to actually undergo this kind of interventions. And if you are 32 and above, but you have other risk factors such as if you have reflux, if you have heart disease, or if you have diabetes, especially diabetes, or you have joint pain, or you have stress incontinence, or if you have infertile, those are indications that perhaps surgery will be a good option for you too. So these are the guidelines that we use across the board. And I'm not talking about my own opinion. I'm talking about a cohort of surgeons, experts in this field in Asia Pacific region and across the world. So what do we do if we have a patient, for example, this patient of mine who is so obese? I was still very young at that time. And you can clearly see that he's very obese, and the main problem is osteoarthritis. She could not work. She cannot step up of the house because of his joint pain. And therefore, we have to go and see him. And because he cannot come to the clinic because of his inability to walk. And of course, we brought our team there and have a home visit. And what do we do before considering surgery? And these are something that we commonly do. We will assess your risk of diabetes. We look at your kidney functions. We look at your liver function, because majority of you will have fatty liver disease. Your liver might have problems, and your kidney might have problems as well. And we have to make sure that you being obese is not because of hypothyroidism, because your thyroid has a problem. So that need to be adjusted, and that need to be monitored when you lose weight. And of course, some patients, because of their endocrine problems, they put on weight, and that need to be corrected before we can introduce surgery. And we need to look at liver size, because your liver size is very big. It makes surgery very difficult. So we will have to make attempt to reduce that liver size by pure dietary modifications, by putting you on very low calories liquid diet. And of course, we need to assess your fitness or cardiovascular, your lung functions, how fit you are, how active you are. We will introduce physiotherapy as well. And of course, your mood. What happened to you if you have lost weight? Would you become depressed or rather become happy again? And your eating habit. Is there any problem in your eating habit? For example, if you relieve stress by eating something very sweet, and if you don't have that escape route, that might make you very depressed if you are unable to eat sweet again. And I'm telling you that after this form of surgery, you can never eat sweet again, especially after gastric bypass, because you will have fainting episodes, what we call dumping syndrome, if you're taking something very sweet after this kind of surgery. So you will not be able to eat sweet. And if that is your escape factor, then surgery may not be a good option for you. So you need to think through that. You need to modify your psychosocial factor. Or unless you are very sure and you are able to change your habit and say that, no, I don't need sweet to escape from stress. I don't need eat sweet to escape from depression. So that's fine. If you can modify that, then this surgery can become a good option. So in order to decrease the risk of the surgery, so we have to optimize your medical conditions. We have to improve your fitness through exercise, and we will give you a pedometer to make sure that you do take 10,000 steps a day, because you need to do that. This surgery is just like a tool, a toy that I give it to you. And it's up to you how to use it. So if you don't use it well, I'm sorry, you still put on weight. If after the surgery, you got this very specific and nice little tool to be given to you as a gift, if you don't treasure that, if you don't exercise, you still put on weight. You need to set a very realistic goal. You need to control your diet so that you no longer eat sweet again. You need to take food in small volume in order to control your weight. So if I give you a small stomach and you force yourself to eat very much, I'm sure that small stomach can go over the time become bigger as well. So you have to look after that. So it's not like I've done this, it's 100% that it will work for you. You need to be on our side. We need to work together. Work together. Same goal. Set a realistic goal and be on the same page. Then it will work. And look at this lady, a patient of mine. Yeah, before surgery, exercise. She cannot walk 10,000 steps. She can't. So she have to do this upper limb exercise to burn off the extra weight, but also to train her fitness as well before surgery. And look at that. After surgery, she lose weight and more and more. And I'm sure with the current picture, you won't be able to recognize her anymore. And I'm just showing this graph because it just point out to you that this is the reason for you to do this surgery. We call bariatric, means you do weight loss surgery, but the gray one means you do this surgery for metabolic reason, for diabetes, for your risk of having diseases that might kill you. And you can clearly see that over the years, the reason for us to do more and more this surgery is no longer about weight loss. It's not cosmetic. It's about to make you a fitter, a healthier person, to make Malaysia healthy again. And that is the main goal of this surgery. And if you look at the types of surgery, I'm just going for the time limit. I'm just going to tell you about two commonest type of surgery that we do nowadays. And one is gastric bypass, which is actually my favorite surgery because I was well trained in this surgery in UK and Australia. And you can clearly see that this gastric bypass surgery has been around the corner for a long, long time, way back in 1970s that we're already doing gastric bypass. So this is a very well-established surgery with good track record. We're looking about data beyond 20 years that you can look at. And of course, recently in 90s, that we started to look at what we call a sleeve gastrectomy, which made your stomach like a tube. And that has a good result as well because that predominantly is to limit the amount of food that you eat. And the bypass is both restrictive and also it causes malabsorption. So I'm just going to explain to you briefly about what a gastric bypass is. So effectively, I cut your stomach and then make your top end of the stomach into a little pouch. It's only about 20 ml of pouch, very small, about a fist size. So after the surgery, the amount of food that you can take each time is only about one fist size, no longer a big plate of food that you can take. So you can only take a small portion of your food for each meal. And we connect this small pouch with the small intestine. and then this joint lower downstream to another intestine that come out from the stomach. So the food no longer go through the stomach, it kind of go around the small bowel, and then during this journey, the food did not undergo any digestion at all because there was no digestive enzymes. Only when it comes to the part whereby this small bowel join the small bowel, there is the enzymes that come out from here, from this small bowel here, from the pancreas, and they all come down, and the bowel as well come from the liver, they all come down, and here they start mixing, and that is where you start having digestion and absorptions. So that's why it's called a malabsorption, because it divert your food so that it take longer time for food to travel before it can be absorbed, can be digested. So it's called malabsorption. It's a good tool because it allows 70% of your excess weight. But how does it work? Because that is the thing. It helps to make your diabetes in remission. It make you don't feel like eating again. You no longer feel that you want to eat a big meal. Is there a reason why? Yes, because in the stomach, at the top of the stomach, there's a hormone called ghrelin. Ghrelin, when you have food in the stomach here, it stimulates ghrelin. And that ghrelin increases your appetite, make you feel like, I want to eat more again. What a nice curry. I want to eat some more, you know? So when you have food in the stomach, that is what it does. It stimulates you to eat some more. But if your food actually bypass this part of the stomach, when it come down to here, going down to here, it didn't stimulate your appetite at all. So after a small portion of meal, you feel fine. I'm full. I'm happy. I don't have to eat anymore. And because the food no longer come down to stimulate this part of the small bowel, that is why this part of small bowel, the hormone then changes. And we know that after this surgery, the gut hormone, the hormone in the gut, they all change. And because of these changes, that's why your diabetes went into remission. And we know that because there are a lot of studies that look into the peptide YY, all these hormone, that changes. And because of that, your diabetes actually went into remissions. And that's how you achieve your weight loss as well. But is there a is there any side effects, any risk? Of course, for any surgery done, you have a risk. Any form of surgery would have a risk, regardless small or big. And of course, we do staples and we cut your stomach, we do joints and all these things, and that actually have a risk of leakage. And that risk is small, about 1% to 5%, which is acceptable. But there is a small risk of that, and you need to know that. And of course, for any surgery, there's a risk of dying from the operation as well. And this risk is documented to be 0.5%, depending on your BMI. Of course, if you have BMI unrecorded, that risk is much higher than those BMI of 32 or 30 or 35, So it depends on what are your underlying risk factors, and that increases your risk of dying from this surgery. That risk is very low. It's 0.5. It's much lower than your heart surgery or bypass surgery or anything else. And of course, there are other complications, like you may have the joint might become too small, and because of the scar, then you start to have vomiting, and that sometimes require a bit of dilatation to resolve that. And sometimes your joint may develop ulcers that make you feel unwell and vomiting as well, and that require medication to resolve that. And of course, malabsorption being a common problem, so you may become anemic because you don't have sufficient iron, unable to absorb iron, unable to absorb vitamin B12, and unable to absorb your calcium, because calcium predominantly absorbed during the beginning part of your small bowel, and that has been bypassed. So your ability to absorb calcium reduced, and that's why you may have osteoporosis, a brittle bone. So you need to replace all this. It's not a problem as long as you follow the replacement therapy. Just take your multivitamins, your iron and your calcium, vitamin D, then that will resolve. And of course, you will have risk of having gallstone as well, and that most of them will require a gallbladder surgery later on. But not a problem. This patient of mine, the next day after surgery, 5 liter holes, no problem. He is happy, no pain, and that is the day after surgery, not in ICU, but on the normal ward. So after surgery, for a bypass surgery, you can drink after 24 hours. Sometimes we do a bit of X-ray study just to study the pouch, to study the joint, make sure there's no leakage. And if that's okay, you can start your oral fluids, and then you can take oral painkillers. We avoid NSAID, those like that can cause ulcers. We avoid them. So predominantly we use paracetamols, etc. And of course, like you change your diet as well. Yeah. Hello. So these are the nutritional deficiency that might develop after surgeries. So all are multivitamins, zinc and iron and ferritin, selenium, and all this can be acquired through your medications. So you can take a tablets or two that can replace this every day after surgery. So you need to do that. So that can be replaced, and you need long-term medical follow-up just to follow you up to make sure that you don't develop any kind of malabsorption problem. So the other new kid in town is this rather simple surgery, just staple across the stomach and make into a tube. And that is rather easy, and it can be done really rapidly. Sometimes the staple line you may need to reinforce with sutures if you are afraid of the staple line leak. I think the most of the risk for this surgery is that there is a risk of leakage from the staple line, because after this your stomach become a very narrow tube, and that put the pressure up in the stomach, and it may cause leakage. So this require rather good technical skill to prevent that, and it can be done. The risks are acceptable. And wow, and in some patients, the results are rather good as well, because same, they can get diabetes resolution as well after this surgery. Although their result is not as good as a bypass for diabetes, but I think you have to decide which kind of surgery you prefer, because for sleeve gastrectomy, you no longer have a bypass, so you still have your absorption of calcium, your iron, etc. So you less likely to develop malabsorption problem, and less likely need to take multivitamins. But most of the patients still take multivitamins just to improve the fitness. And you can clearly see that even after sleeve gastrectomy, this is my patient who was a registrar at UM, and you can clearly see that even after sleeve gastrectomy, she can lost a significant amount of weight, even at the age of 60 years old. Significant, even just through a very simple sleeve gastrectomy. And of course, after the surgery, is there any complications? And I think some patients may at risk of develop depressions because of the food issues. The one that I talk about is that if you eat sweet to escape from depression, then that been taken away from you, then you might become a bit of a problem to overcome depression again. And some may miss the meal that she had before, and like having a big meal, they no longer can take that, so that may make them depressed. So this require monitoring and counseling as well, and make sure this is exactly what you want in exchange for better lifestyle, better health, and 10 years of your lifespan. Are you able to exchange that? And of course, if you lose weight, you become much more attractive, and there might be changes in relationship. Beware of that. Divorce rate might go up. So you have to be very careful. Manage your family well. And most patients may have hair loss, but usually temporary. This is because they haven't adjusted your diet well. They have to remember, because they eat so little, so their protein intake must increase. Their protein that they take, the meat that they consume, must be high quality meat, although not a big volume, small but high quality. So if your protein intake is good, or you can take protein powder like myotin, then it will help to prevent hair loss. And of course, zinc, such as the mineral like zinc, vitamin A, you need to make sure that you have sufficient of that to prevent hair loss. Is there a problem with excess skin? For example, if you lose so much weight, a lot of people worry about, what about those baggy skin? what do I do with that? And well, I think if you are still young, like this is one of my staff nurse, and you after surgery, you don't need to go under any form of cosmetic surgery. Your body, if you are active enough, you do a lot of exercise. If you are young enough, you still have that elasticity, and your body will still get toned up, and you still look nice without having any corrective surgery. And if you are like this patient of mine who cycle all the way from Malacca to Penang on a bike, if she can do that, her body get torn up, so there's no need for a skin reduction surgery. But of course, if you have significant problem of that, you can always visit a plastic surgeon and have abdominoplasty, which means that a reduction of your abdominal skin or your flabby skin here in your arm. You can have an arm reduction or leg reduction surgery to tighten up your skin. That can be done. In the West, some patients actually do that, but in the East, I think you just have to weigh the risks and benefits. And of course, earlier on, I talked to you about you have to take calcium tablets, your iron tablets, and you have to go for either a long-term oral vitamin B12 tablets or a regular vitamin B12 injection every 3 months, and the fat soluble vitamin as well. Of course, we recommend you to take acid suppression medications for at least 6 months to prevent any ulcer formation at your joint. And of course, gallstones development, and you might require some gallbladder surgery. And I would say avoid pregnancy for the first year, because during that first year, you become very fertile. Make sure you have taken precautions, because at that first year, your metabolism is still you're still in the process of rapid weight loss. So you don't know whether you absorb enough folic acid. So you must make sure that you're not deficient of folic acid when you get pregnant. So that is very important to know. So usually we recommend a year after this surgery. That is when your body become more stable, better for the baby. And of course, there are rule of thumbs for eating as well. So if you eat, you must make sure that you're just like a monk. You eat in a small amount, but with minimal stress. Enjoy your food with no distraction, focus, mindful, and then you take your food in small bites. And you progress your diet after surgery from liquid to semi-solid and later to a solid food. So you have to take progressions, eat small portions, make sure you chew very well before you actually swallow the food. And if you feel your pouch, you feel that it's full, stop eating. Don't force yourself and make the pouch bigger. And of course, you are not supposed to drink when you are eating. You have to have dry meal, because if you drink with your meal, you basically can flush anything down the toilet, right? You can flush whatever food with your drink. If you drink beer, even worse, because beer has a lot of sugar and the beer has gas and make you rather uncomfortable. But if flush your food down the pipe. So do not drink with the food. And you usually wait until at least an hour after you eat, then you drink plenty of water, because you need plenty of water, otherwise you become very unwell. So that is the rule of eating. And if you develop vomiting after this form of surgery, then you have to know what is the problem. Maybe you eat too much, and so you stop eating and drinking for a while, and then you maybe cut back to liquid diet rather than having solid diet. Maybe it's just a bit too hard for you to go through. So, but if continue to have vomiting, then you need to look for the surgeon. So earlier on, I showed you the bypass surgery and the sleeve gastrectomy. So basically, if you have bypass surgery, the amount of weight loss that you achieve is much higher than a sleeve gastrectomy. But of course, there are instances like the other lady that I did, just a sleeve gastrectomy alone has sufficient weight loss that doesn't require a bypass. So it depends on individuals, but by and large, based on the data and the population, a bypass, you lose more weight. And so you have to balance the risks and benefits of either of the approach. So, and this study basically look at comparing the surgery and the intensive medical treatment for diabetes and looking at 5 years. But what basically it says is that if you have surgery plus if you have very good medical treatment, it's much more better. Is a very effective. I just want to highlight to you here, very simple, in that they just highlight to you, okay, this is a gastric bypass, this is a sleeve gastrectomy, and this color is insulin, okay? You require insulin before surgery. After surgery, very few people require insulin injection, okay? And this color represent no treatment. So before surgery, all of them require treatment, but medications and insulin. But after surgery, a significant, almost half of them do not require any more insulin or any more medications. Same for sleeve gastrectomy, but for diabetes, for sleeve gastrectomy, the effect is not as good. It's only 25% that actually fully come off from the medication. But the insulin usage has reduced as well. So by and large, if for diabetes, a gastric bypass, I would say, is better than a sleeve gastrectomy. But if you have no diabetes and you just purely want to lose weight, then a sleeve gastrectomy might be a good option. So what happens if you already have complication of diabetes? What happened to them? Would they have any benefit from this? And if you look at complication being small blood vessel complications or big blood vessel complications, and you can clearly see that after surgery, they do have improvement of their complications. And if you look at this, just look at the small blood vessel complications from diabetes. I just highlight to you like microvascular complications, those that because of side effects, the complication of small blood vessels, those who underwent surgery, their complication actually reduces. And we are talking about like the effect on the kidney. If your kidney was badly damaged by the diabetes, developed neuropathy, actually they improve after this kind of surgery. And if you have nerve problem because of diabetes, they actually also improved. Rather interesting. And if you have eye disease because of your diabetes, that actually also improve after surgery. So that is interesting. And because of this improvement in the disease profile and also in medication, in other words, you come off from your medication, that actually in long term actually save money, right? If you have reflux, you no longer need to take your medications. If you have diabetes, half of you come off from the medications at least. Hypertension equally, and the cholesterol, hypercholesterolemia as well. So all this, because you come off from the medication, you actually save the money. Unfortunately, at the moment in Malaysia, unlike in United States, this form of surgery is not covered by insurance. And we are trying to explain to the insurance company that if you have this form of surgery, in long term, you actually save money in terms of medications and in terms of your insurance cost, because less likely for you to have cancer, less likely for you to have undergoing expensive cancer surgery, less likely for you to have a prolonged medical treatment for diabetes or heart disease. So in that sense, it translates into a better saving. So after this surgery, what happened to the patients? These are my patients. Do they still feel good after surgery? Yes, I think all of them feel really good. This is my patient from Australia, and she came because she want an adjustable gastric band. Because so happened that the gastric band at that time in Malaysia was cheaper than in Australia. So she flew all away from Australia to Malaysia, KL, just to have that band put in. And she have achieved a significant weight loss. But band is no longer considered the treatment of choice nowadays. In fact, in Australia, most of them has stopped doing bands already. And in Malaysia, you cannot find a band anymore. So that's why I don't talk about gastric band now. It's not available in Malaysia. And my patients, after weight loss, able to pursue a study in United States, America, having a good college campus life and having a good night out. Unfortunately, being in America, you tend to put a little bit more weight. So that is the side effect for being in America because of the dietary changes. And of course, after surgery, you can clearly see that it's much better, isn't it? The lifestyle, looks like a more successful person indeed. And but bear in mind, if you lost weight after surgery, don't put the extra meal that you cannot take to your children, because otherwise your children will develop obesity as well, because 10% of them will be at risk as well. So beware of that. And of course, it's a it's different. Just words cannot describe, but I can only show you by diagram and pictures. And of course, what kind of life is this? I think happy, isn't it? Happiness. So change of lifestyle after gastric bypass or sleeve gastrectomy, you have more progressive lifestyle, been much more happier person. But of course, there are also downsides. Some patients come back to me, say that they miss eating big bowl of curry laksa, they miss eating big bowl of char kway teow or the curry, you know, and some of them do miss them, but this is a trade-off. All I can say is that it's a trade-off that perhaps it's important for you to look at. If you want to make yourself healthier, if you want to make yourself uh, better looking, but better looking is very subjective. Some people prefer to be fat and other prefer to be thin. So I wouldn't say that this is a cosmetic surgery. It's not, because beauty in the eye of beholder, but it's the health. If you lost weight, you resolve your diabetes, you resolve your cardiovascular disease, you don't have joint pains, you can have more active lifestyle, you can enjoy life to the fullest, and you can gain 10 years of your extra life year. What more to ask? And I think this is a trade-off that you can think about. So, ladies and gentlemen, I'm just trying to explain to you that obesity surgery is not what most people think that is a cosmetic surgery or a lifestyle surgery. It is not. And the form of surgery that we do has scientific data, and it does maintain your weight loss to even beyond 20 years. And it does have a significant improvement in your health risk as well that is associated with obesity. And we do know that it increases your at least 10 years of your lifespan. And on a longer term, I think it is a cost-effective surgery. In Malaysia, it's still not covered by insurance unless in a very exceptional circumstances. Um, but it's an investment that been recognized by the government, and I think in Malaysia you can actually use your EPF Part One to withdraw that EPF for this form of surgery, and the government do recognize that. So there is some of the patient, in fact, did consider that, is aware that the government actually recognize the effectiveness of this surgery. But by and large, I think it certainly is something that is worthwhile to look at. It is really is a cost-effective way of treatment. Thank you very much, ladies and gentlemen. So hopefully after you hear my talk, you can look at the mirror again. What do you want to look at? Will you take it as a form of treatment? And of course, I must not, this is not to tell you that this is the only way. This is one of the way. And whether this way is for you, you need to come and talk to your surgeon, your doctor who does this surgery. And there are surgeons in this country who does this surgery, apart from myself. And we represent a cohort of surgeons. They have experience and good results to show you. And I'm sure my colleagues and I across the country and in the region as well, Asia Pacific, that we can actually help you to answer some of your questions. Thank you very much.
Thank you so much, Professor Dr. Chin. That was so amazing, especially the transformation pictures. They were so amazing. How I'm sure you made a big change in their life. For example, like anybody feels good in getting into a smaller size clothes. And
Yes.
I like the one you said, this is not cosmetic, it is also for the
Yeah.
health. So that was really, yeah, thank you so much for making people's life better, Professor Dr. Chin. So
Thank you.
we have a few questions coming up. Before that, I have one question.
Yes.
How do you measure who need gastric bypass or sleeve gastrectomy? Is it the patient who decides, or you will decide according to their body weight?
Yes, I think by and large, there are many different types of surgery, so we call subtypes. But by and large, there are two main types that we recognize. One is a very well established gastric bypass. The other one is a much easier to do sleeve gastrectomy, which is much more popular in Malaysia and depends on the surgeons and their experiences, whether which one they prefer to do. So the surgeon have to be realistic as well. Am I comfortable to do a gastric bypass? Because gastric bypass technically is a much more difficult surgery to do than a sleeve gastrectomy.
Oh,
But I
yes.
think the risk of the surgery is about the same. The risk of leakage from the stapler line, they are all about the same. And the risk being translated because of the weight and because of other comorbidities. But by and large, I will explain to the patients, for example, if they have a metabolic illness like diabetes, especially diabetes, you can clearly see from the data that gastric bypass work better for diabetes because that is the mechanism. The bypass somehow changes your gut. It changes your gut hormones.
Yes.
In fact, that become such a exciting scientific findings that we still cannot fully comprehend, which is the factor that actually made the diabetes just just resolved, overnight. So that is the mechanism that probably better for patient with diabetes compared to a sleeve. But of course, some patient may say that, oh, I don't want to take tablets, so many tablets, multivitamins, and all these risks of malabsorptions. I just want to have a sleeve. Yeah, that is okay. As long as they follow a medical treatment. I must say that after this surgery, this for diabetes especially, you must go and see your diabetic doctors. It's a long-term follow-up, regardless whether you have surgery or not. They must see the doctor, diabetic doctor, not only surgeon alone, because the diabetic physician is the one who will follow them up, who will manage them, and
That's
because they
great.
need to be looked after as well, even after resolution of the diabetes, need to be monitored. So basically, that is what I will explain to them. And if they have a gastric reflux disease, for example, then a gastric bypass actually was the first anti-reflux surgery in this world. It was
Okay.
used to treat reflux disease, and because of that, before it become like other options like fundoplications and those kind of things. So if they are obese and they have reflux disease and they need to have surgery for the reflux disease because medication doesn't work, then I will tell them that do a gastric bypass because it can treat their reflux disease and it can treat their obesity as well. You kill two birds with one stone. Finish.
Yes.
Done. Yeah. You can still do I gave a talk at the Asia Pacific meeting about sleeve gastrectomy can be considered for reflux disease as well. And I have to make myself clear that, oh, I usually do gastric bypass for reflux, but for this purpose of the talk, I must explain to you that why sleeve gastrectomy can be done as well. And I did quite a lot of research. Yes, if you want a sleeve gastrectomy and you have reflux disease and a hiatus hernia, it can be done as well, but we have to repair your hernia and we have to do some modifications, and it can be done. But by and large, I think if you have diabetes and reflux, my personal opinion would be to go for a gastric bypass because that is what I'm specially trained for. Because when I was in United Kingdom as a consultant, upper GI surgeon, we do gastric bypass only,
Mm.
and all our patients get gastric bypass. So I have a lot of experience in this gastric bypass surgery. But
Okay.
sleeve gastrectomy we do as well because it's just a toned down kind of surgery. Yeah.
Okay. Thank you, Dr. Tin. There are many questions coming up. So let's go straight to the questions. Let's see. It's from Jukama Tay. How soon can stop the diabetes medication after the surgery?
You can stop insulin injection the night after surgery. That
Wow,
very
amazing.
evening, you stop your insulin because your
Mhm,
blood sugar will return back to normal. We've done
mhm,
that study. It's been shown in the data that it
mhm.
just normalized after surgery. So
Okay.
normally we don't start medication at all after surgery. We just observe, and then we see
Mm,
whether their glucose return back to normal, and if they still bounce back, whether is there any other oral medication that is required. But from the data, you can clearly see that for gastric bypass, I'm talking about
mhm,
gastric bypass. Most of the data
mhm,
come from gastric bypass,
mhm,
and that the night after surgery, none of them require insulin
mhm,
at all. And I mean, you're talking about 50% will come off the medication all completely.
mhm.
Hypertension take a little bit longer. Hypertension may take about 6 months before you tailor down your
Reduce. Mhm,
medications. So usually you have to watch that. You have to work with your surgeon, and not only that, work with your physicians. It's a
physician.
team approach. It's not only me alone. It's together
Mhm,
with other doctors, like your
mhm,
your doctor will look after your diabetes, your doctor will look after your hypertension. We all
mhm,
work together so that we can tailor down your treatment and still monitor you because we still need to keep an eye on you.
mhm. Okay, thank you, doctor. Can we have the next question? It's from Ishwar Khanna. How to avoid flabby, I think flabby skin after bariatric surgery. But I think
Well,
you
I
answered
think
in one of your
yeah, you
slides.
need to tone up.
Mhm.
You need to tone up. You need to find a friend who does go to gym with you, do a lot of weightlifting, and need special toning exercise. You need when you're in hospital, talk to your physiotherapist. They will be the
Mhm.
one who teach you how to tone up your skin. Yeah.
Mm. But I think they before they could go for surgery, they can prepare all this after surgery, post surgery exercises.
Yes.
They can enroll in a gym where. So
Yes.
my question: how soon can they start all these toning exercises?
Usually, they if they are really good,
Mm-hmm.
we will probably say that they only need to stay in hospital for three days, and some may go back earlier. And
Mm-hmm.
usually because it's a minimally invasive surgery, only keyhole surgery. It's not like last time big cut. It's a small
Yes,
little cut, small holes, five
it's a
holes,
laparoscopy.
and that's all you got. And
Mhm.
in fact, I also do one hole. In fact, I can tell you
Oh.
that in
Mhm.
Klang, there's a lady that have a one whole gastric bypass surgery done by me, and nobody know that she had this surgery because in her
Mhm.
body there is no scar.
Mm.
It's
Okay,
called
very good.
scarless gastric bypass, but that is really technically very difficult, lah. uh, yeah,
Okay,
so you recover very fast. Yeah.
okay. What type of food recommended?
Mm. After surgery,
Mm-hmm.
um, you take high protein, small amount. It has to be high protein. Protein is very important because otherwise you will not have sufficient energy, you will not have sufficient amino acids. So you need to have high protein, low fat, and low calories. Yeah, and make sure you have vegetables as well because otherwise you have constipations and bad
Mm-hmm.
breath. So vegetables and fruits are important as well. But you
Mm-hmm.
have to judge your volume. You have to make into a small portion, and you have to say, oh, that big piece is protein. Yeah,
Mm-hmm.
there's a lot of science in that. Yeah, perhaps I think my proposal is that for you to organize a dietary session on this, and dietitian and I
Oh,
can have a talk about this.
yes, sure. We can work that out.
Yeah.
We'll go to the
But
next
before
slide.
surgery, we normally recommend a very low calories liquid diet,
Mm-hmm.
less than 800 kilocalories per day for at least 2 weeks. That is
Mm-hmm.
to shrink down your liver size. Because for
Mm-hmm.
ladies especially, you put all your fat in your liver. So when you go in, your liver is so big that you cannot even do the surgery at the top of your stomach. Because if I lift up your liver will bleed because it will
Mm-hmm.
fracture because it's so fiber, so soft and so big. You just
Yeah.
cannot see anything. So we give
Mm-hmm.
you 2 weeks of liquid diet to lose weight and also to shrink down your liver size.
Liver, yes.
And for men, we put on weight in the tummy, a lot of fat in the tummy. So you go in, you see your fat,
Mm-hmm.
you thought your tummy is very big, but inside is very small. So for us to
Mm-hmm.
work with. So we say we put you 2 weeks of weight loss so that we get rid of some of your fat before you go in.
Mm-hmm. The fatty livers. Okay, the next question. If my family member has gone through bariatric surgery, how can I be a support?
That is an extremely good question because that is what we face with family support. I think
Mhm.
when the patient come, it must be a joint decisions. If you're married with the other partner, okay, you need
Mhm.
to work it out. It has to be a family decision because after surgery, just imagine your diet will have changed, right?
Yes.
The way you eat will change.
Mm-hmm.
You go out, people having a 10-course meal, you sit down there and say, I only have a little bit, you know. And a family occasion, everyone look at you, what are you doing? They cannot see that you undergone surgery because there's no scar, okay?
Mm-hmm.
Keyhole surgery, right?
Mm-hmm.
And then your family have to support you lah. Say, oh no, no, it's okay. She changed her diet. She only eats small amount, okay?
Mm-hmm.
And don't force the patient to eat, and
Yes.
don't make fun of them if they don't eat so much, you
Mm-hmm.
know, and buy good meat for them,
Mm-hmm.
and of course, join together, enrich your
Just to
lifestyle.
support. Mm-hmm.
Yeah, go to gym together.
Mm-hmm.
You have a bit of competition because your partner will lose weight, become more attractive,
Mm-hmm.
and you have to go to the gym to
Talk
turn
to
out
it.
as well. So that both
Yeah.
of you become
Mm-hmm.
compatible.
Yeah. But I
So
think
it's
family,
about
as you said,
motivation.
they
Motivation.
play a big role where I would say do not store junk food in the refrigerator and things like
Correct.
uh,
Correct,
support
correct,
each
correct.
other.
Yeah,
Like
yeah,
I
yeah,
know you
yeah.
can eat, but it doesn't mean you store it because I'm also
Mm,
there. So yeah.
yes. I got a patient of mine who had this
Mhm.
surgery and he had the support of the wife
Mhm.
and the wife also thinking about it also, but he has the support of the wife. So after he lost weight and he changed his
Uh-huh.
diet and then he found that he just like to munch along. He just
Mhm.
want to eat something because of MCO, right? So nothing to
Mhm.
do at home. So he like peanuts and what sweet and not sweet like chips and all these things. Then the wife was get very upset, then complained to me. Then say have to cut it off, cut it off. Then in the end he come back and say it's all gone now because the wife say cannot take.
That's good.
Yeah.
Okay,
So have to
next
work together.
question. Yeah.
Yeah.
Uh, do they need to take extra supplements since the nutrients are not absorbed?
Yes, they need to take the supplements. This is very serious questions
Mhm.
because especially for gastric bypass, sleeve gastrectomy less of a problem, and that's why maybe some patients may decide to choose that if they don't like
Mhm.
taking tablets.
Mm.
Basically, nowadays you can buy very good tablets, multivitamins with all
Yes.
the vitamin D, calcium, and all
Mhm.
the multivitamins all together in one tablets and with all
Mhm.
the minerals you can choose whether selenium or zinc and all these things, then you can take that. And vitamin
Mhm.
B12 you can come for injection once in every 3 months or 6 months if your store is sufficient. If not, you can take vitamin B12 tablets, but you have to take it every day. and
Mm.
uh, and the iron tablets as well. So you have to
Mhm.
monitor that as well. So now and then you may need to do some blood tests to check
Mhm.
your vitamin levels. You can check your levels if you want to.
Mhm.
Like you can check your zinc level, is it sufficient? Selenium is one of the things, trace elements that you
Mhm.
really need to replace. So these
Mhm.
are the things that you need to be aware of. Yeah, it can be
Mhm.
done. It's a trade-off. It's
Mhm.
a
But I think
trade-off.
basically you just have to move close with your physician and your
Yes,
surgeon as
yes,
yeah along
yeah.
this way till you get your weight. And then, doctor, actually, I have one question. Just now in one of your slides, you say you have to avoid NSAID for the after
After
surgery.
surgery, yes.
Will that be for throughout, or is it just for a short term that you have to avoid the NSAIDs?
It's just short term because after surgery, your staple line and your joint, they are at risk of bleeding or having an ulcers. So we don't want that to happen because if that happen right after surgery, during the first week or two, then it might cause a problem. Like you may have suddenly
Mm-hmm.
have a bleeding or perforation, and we don't want that. So we normally say that we cut off that, and
Mm-hmm.
then we put you on some alternative pain relief like cocodamol, paracetamol, or
Awesome.
tramadol, something like that,
Mm-hmm.
or Ultrasec. There are plenty of other alternatives. Yeah.
Mm-hmm.
It's just that we try to avoid that. But then after that, once everything heal up, when everything stabilized, I think there's no problem. Yeah.
Okay. I think we have one last question. How to cope with cravings for favorite food after bariatric surgery? Actually, I wanted this too.
Hmm.
Because
You
let's say,
have
for
to,
example, you love to eat chocolates. As I
yeah.
think in one of your slides, you did say that emotional eating, like, you need the family support to
Yes.
eat your favorite food. Yeah.
Yes, so that is very important. The main thing is insight. You have to know
Mm-hmm.
why you need to take your chocolate. Okay,
Mm-hmm.
if that is because you are avoiding stress or one of the escape mechanism for stress or depressions, then you need to undergo perhaps a period of psychotherapy, or see someone, a psychiatrist or psychologist, or even your friends or someone to talk about it. Are you
Mm-hmm.
able to change that? Because most of the time, I can tell you that there are alternatives. For example,
Mm-hmm.
if you find that eating chocolate is your way of mechanism of escaping stress, you may change that to, for example, mindful breathing. You may go for
Mm-hmm.
meditations. You may use that technique as a way to relieve your stress, and you do
Mm-hmm.
that first. Once you overcome that, then you say, okay, I don't need chocolate to escape stress anymore. I can just watch my breath in and out, and that stress is gone.
Mm-hmm.
Then you come for surgery. Then that is very good. And if you like to eat sweet, some actually, in fact, in UK, we ask these very common questions. If you are a sweet eater, then we won't do sleeve gastrectomy for you, because there's no use, because I made your stomach so small, like a little tube. Then you still eat your sweet, it still go down like pipe, and then you still put on your weight because you just drink Milo, you know
Yeah.
your high sugar content, whatever
Mm-hmm.
that you take, then you still put on weight. So it's not
Mm-hmm.
effective. Then we will say that, you serious?
Mm-hmm.
You don't regret? I do a gastric bypass.
Mm.
Because after a gastric bypass, if you take your sweet, you got giddy, right?
Okay.
Then you say, okay, I don't want to have sweet anymore because I will have this dumping syndrome.
Mm.
So then we use that as a way to control their habit. Then after
Mm-hmm.
that, they cut off the sweet. Yeah,
Mm-hmm.
yeah.
And I think it's also eating regular meals and to make sure the blood sugar levels stay even. Then you might not
Yes.
be craving for more food and overeating
Yes,
also.
yes, you need to regulate your meal time,
Mm-hmm.
and in between meal, you need to drink plenty of water
Mm-hmm.
to hydrate you.
Okay.
Yeah, it's about
Okay.
healthy living.
Yes.
This is just this is
Simple
not
next
magic.
time.
This is
Mm-hmm.
not magic. I'm not talking about a magic wand that you're gone. You're to slim down. No, this is a combined effort. This tool is just like a tool, a gift to you. How you're going to use it is up to you.
Mm-hmm.
If you work with your doctor, not only me alone, work with your dietitians, work with your physiotherapist, work with your diabetic doctor, work with your cardiac doctor,
Mm-hmm.
or whoever doctor, your GP and your friends and relatives, then it will work for you. But
Yes.
if you keep yourself and abuse it, then it will be a waste of effort. You
Mm-hmm.
put on weight and other issues. Yeah.
Okay.
And you might come back and say, can I reverse that?
Okay, thank you so much, Professor Dr. Chin. It was an amazing session, and I'm sure everyone learned as well. And for those who's got more questions, you all can still put your questions down, and it'll be replied through the comment. Thank you so much, Professor
Yes.
Chin. And
Thank you.
is there any take-home message that you would like to give to those who's considering to do this surgery, doctor?
Well, I think if you have the interest, or you have a queries, or you have certain doubts, you can always come and talk to us. Talk to your doctor, or you can come and see me and talk to me, or talk to the hospital. And we, as a medical profession, will try our best to help you. It doesn't mean that when you come and see me, you need to go for this surgery. Sometimes it could be just to inquire, to talk about it, and to find out whether it is suitable for you or not. And
Yes.
this is an options. Yeah, yeah, and talk to your own doctor as well, because
Yes.
you need everyone to be on your book on your side.
Okay. Thank you everyone for
Yeah,
joining. See you on the next show. Have
thank
a
you,
nice day. Bye.
thank
Thank you,
you,
Doctor.
thank you. Bye bye, bye bye.